I'm Dr. Lucinda Bateman. In this session, we'll be talking about orthostatic intolerance. Before I start, I want to remind you of the important principles of management of fibromyalgia and ME/CFS. These are tried and true principles and should kind of guide your approach to management with your primary care and also self-management. The first is always remember to work with your doctor to identify and address all aspects of illness and comorbid conditions. You want to minimize any impact on the symptoms of fibromyalgia and ME/CFS by treating other contributors. Then the most important thing is to learn how to pace your activity to prevent symptom escalation and avoiding the push-crash cycle. We'll be talking more specifically about pacing in a different lecture. Then you want to address the major aspects of illness, achieving restorative sleep, calming any kind of stress and achieving good balance of your mental health, working on controlling severe pain and learning how to live with chronic pain, and achieving the best fitness you can given the limitations of your illness. And at the end of this list is our topic of today, orthostatic intolerance. And not everybody has orthostatic intolerance, but if you have it, treating it might help you feel better and function better. So what is OI, or orthostatic intolerance? It is the development of symptoms while standing upright that are relieved by reclining. So what are the symptoms of OI? Acute OI, or OI worsening in the moment, can present as fainting, lightheadedness. You can feel anxious or short of breath. It can make you feel exhausted or weak. It can make your heart pound or give you shortness of breath. And some people get shaky and have a tremor. Now, if the orthostatic intolerance is chronic and well compensated, the symptoms may be more subtle. It can present as nausea or poor appetite, brain fog, looking pale, being very sensitive to heat, trouble sleeping, and then varied types of dizziness, maybe not quite so pronounced or not severe enough to faint. So orthostatic intolerance is an umbrella term, and there are other terms that fall under the diagnosis of or the description of orthostatic intolerance. One of those is orthostatic hypotension. That means that your blood pressure drops when you stand up, and it improves when you lie down. Another term you might hear is dysautonomia. This just means abnormal autonomic nervous system function. There's a term called POTS, Postural Orthostatic Tachycardia syndrome, that refers to the excessively rapid heart rate response to standing when you have orthostatic intolerance. Neurally mediated hypotension and neurogenic orthostatic hypotension are terms that suggest that the orthostatic intolerance is caused by underlying disease of the nervous system that leads to a drop in blood pressure and eventually fainting from standing. These are all forms of illness that can manifest as orthostatic intolerance. Why orthostatic intolerance? Well, it's measurable by tracking your heart rate and your blood pressure. It doesn't measure everything, but it does measure parts of orthostatic intolerance. And it's treatable, or at least manageable. It's good to remember that OI can exist in someone who has low, normal, or high blood pressure measured in the seated position. This term OI really refers to what happens to your blood pressure when you go from a lying position to a standing position. How do we measure orthostatic intolerance? Well, the gold standard is a tilt table test, but in reality, it may be difficult to find someone to do a tilt table test, and many centers do different protocols for the tilt table test, and so they're not necessarily standardized or set up to measure the type of findings that we may see in fibromyalgia and ME/CFS. I prefer bedside orthostatic science where possible. When I was training, we did a stand test, and that means we would just have the person stand from the sitting position and monitor their heart rate and blood pressure for a few minutes. Now I'm more excited about using a more standardized test, a little bit longer, called the lean test. And we're going to talk about the lean test in the next few slides. Wearable devices that record your heart rate as an indicator of exercise effort can also be an indirect measure of orthostatic intolerance, especially in people who have a rapid heart rate response to standing. So this is a picture of how we carry out the 10-minute NASA lean test. And I'll just tell you, this is, we call it the NASA lean test because in the early days of NASA and astronaut travel, they used a tilt table test, but they also developed bedside testing to measure orthostatic intolerance. So we're borrowing their name as and as we talk about the 10-minute NASA lean test. So you can see that the participant, this is after lying supine or lying down quietly on a bed for 15 or 20 minutes in order to obtain a resting lying down blood pressure and heart rate. That is followed by standing with your feet about 6 inches from the wall, leaning back so that only your shoulder blades are in contact with the wall, and to try to get in a comfortable position. Then we put a pulse oximeter on one finger and measure blood pressure in the opposite arm. Wearable devices like a pulse oximeter can monitor heart rate, and you need to have a blood pressure cuff to measure your blood pressure or have someone else measure it for you. This is an example of the results of a 10-minute NASA lean test of a 58-year-old woman with chronic fatigue syndrome. She's very thin, she has many symptoms, and she had no idea she had orthostatic intolerance. You can see that after she had been lying down on the bed to rest, her blood pressure was 114/76 and her heart rate was 75. Very normal values. When she stood and leaned against the wall in a relaxed manner, we took her blood pressure and heart rate every minute for 10 minutes. And if you look at the blood pressures, you can see that initially the blood pressure looks like it's going to drop, and then it actually starts to go up. And that is because when she stands up, there's pooling of the venous blood in her legs, and there's an adrenaline response to try to compensate for that drop in blood pressure. You can see the adrenaline reflected in the slowly increasing heart rate. Started out at 75 and peaks out at about 100 in minute 9 and minute 10. Meanwhile, even with that fast heart rate, she can't maintain her blood pressure, and at about minute 6, the blood pressure starts turning around and dropping, until at 10 minutes it dropped to 95/50. And if we had kept her going another minute or two, she would have fainted. So her systolic blood pressure, the top number, dropped 19 points. The diastolic pressure initially went up, and then as her tone decreased and she was decompensating, the diastolic pressure dropped more than 28 points. And her heart rate increased 25 beats per minute lying down compared to standing. So this is an example of delayed orthostatic hypotension, and if we'd have continued, she would have fainted. It's also useful to notice that she developed many symptoms and physical signs during the course of the test. And if this happens to you, you can use those as an indicator of your own blood pressure and heart rate in the standing position to remind you. This is just a picture of showing how there's venous pooling even in the hands. When the hands are dangling, you see that the hands are puffy and the veins are very engorged. In this picture, you can see that when the person is lying down in the top photograph, her feet are pink and look well oxygenated and perfused. On the lower picture, during the stand test, she has sort of a bluish reddish color to her feet from the venous pooling, and then her feet are also pale and may start to look a little bit mottled from the reduced arterial blood flow to the feet. And the feet and hands can become very cool during this procedure. This is just a picture of someone who's very ill and bedridden, has severe orthostatic intolerance, and these changes of rubor in her feet have kind of permanently changed the color of her feet. But it does get worse when she's standing. So this is the 10-minute stand test in a 19-year-old male. When we brought him in the chair to take his intake blood pressure, it was 110/64, and his pulse was 80. He had been a runner and a cross-country runner before he developed a virus and then developed chronic fatigue syndrome. He wasn't convinced that he had orthostatic intolerance, so I had him stand in front of my desk with the pulse ox on his finger. And I had him stand there for 10 minutes, monitoring and recording. So you can see that his heart rate started out at 89 beats per minute, and from seated. If we had laid him down flat on the bed, I think his heart rate would have been even lower in the baseline. And you can see his heart rate immediately started to climb, and as his heart rate went up every minute, he began having symptoms, feeling a headache, trouble thinking, leg muscles hurting, and hands and feet feeling very heavy from the venous pooling. And as he approached a heart rate of 129, he was starting to have a tremor and shake all over. So you can see that just this kind of simplified stand test demonstrates that he has POTS, Postural Orthostatic Tachycardia syndrome, because his heart rate went up at least 40 beats per minute during the test. We brought this same patient back to the office to do a formal 10-minute NASA lean test. We also prepped, means we asked him not to wear compression, to stop pushing extra fluids and salt, and just come in his more native state to see what we could see during the lean test. Lying on the bed, relaxing, his blood pressure was about 130/60, and his heart rate was in the 80s. The pulse pressure is the difference between the top and the bottom number of the blood pressure, the systolic and the diastolic number. And his pulse pressure was 69, the difference between those two numbers. Imagine you're feeling a pulse and you're feeling a big bounding pulse because of the difference between the high and the low in pressure. When he stood up, put his shoulder blades against the wall, and allowed us to start taking blood pressure and heart rate measurements in the standing position, you can see that his blood pressure begins to drop and his heart rate goes up dramatically. And the heart rate is basically able to sustain his blood pressure quite a bit lower than it was when he was lying on the bed, but not low enough to faint, and his heart rate went up to 128 beats per minute during the course of the test. This is a 46 increase in heart rate, also meeting criteria for POTS, but he also had a drop in systolic blood pressure of 20 during the test, which meets criteria for orthostatic hypotension. I'd also like to call your attention to his pulse pressure. Toward the end of the test, his pulse pressure was only 28. That's a 60% drop in pulse pressure, and you would be able to monitor that by finding it very difficult to feel the pulse. It would become very thready and very, very much lower than it was when he was lying on the bed. Here's a 32-year-old woman with severe migraines, fibromyalgia, depression, and all kinds of dizzy complaints. We had her hold her morning medicines so that they would have less impact on the test, and take off her compression clothing for this NASA lean test. Her blood pressure and heart rate, rested lying on the bed, was about 116/50 and a heart rate of 85. The pulse pressure, 54. As we stood her against the wall and monitored her blood pressure and heart rate, we could see immediately that her blood pressure went down, 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 and her heart rate went up and up and up. It's also the lowest at 10 minutes. Well, actually, the very lowest was at 6, 91/73, and the highest heart rate was 123. But what's very interesting is she could feel the symptoms of the orthostatic intolerance. She felt tingling sensations, lightheaded, dizzy. She even got a spinning kind of dizziness, nausea, and toward the end of the test, she felt an electrical buzz that reproduced many of the symptoms she'd been feeling and didn't understand. And you can also see that her pulse pressure was only 13. So the pulse pressure went down by 76%. This is an indication that the cardiac output has diminished significantly due to the venous pooling. This is a 37-year-old woman with ME/CFS. She has an average tolerance for upright activity in a given day of about 2 to 4 hours, plus or minus, depending on what it is she needs to be doing. You can see that her seated blood pressure and heart rate look very normal, 112/75 for the blood pressure and 77 for her pulse or her heart rate. Her pressure lying down was very low, 99 and relaxed, 99/68 with a heart rate of 68 and a pulse pressure of 31. So this is a person who from the start of the test has a very low blood pressure and a low circulatory pressure. As we stood her up to do the lean test, there's a jump in her heart rate to try to compensate for this the drop in blood pressure and the venous pooling, and that sustains her blood pressure for a while. It becomes more and more difficult to hear the blood pressure because of the low pulse pressure. She developed tingling, nausea, and at minute 6, you can see that her heart rate peaked at 132 beats per minute and her blood pressure was only 88/62. At that point, when her heart rate started coming down and her blood pressure stayed down, she was about to faint. So we ended the test early and helped her sit down and put her feet up to recover. Her heart rate increased 64 beats per minute, which is very excessive and easily meets the criteria for POTS, but she also had orthostatic hypotension, not meeting the criteria because she started at such a low point. So what do we know about orthostatic intolerance? Well, the circulatory system is controlled by your autonomic nervous system. And this is a diagram showing the balancing parts of your autonomic nervous system. In the red, the sympathetic nerve fibers come off your spinal cord and go to all these organs to signal your fight and flight response, adrenaline. On the left are the counterbalancing nerves of the autonomic nervous system called the parasympathetic nerves. These are the nerves that override the sympathetic response and allow you to rest, digest your food, and these should stay in balance to help you meet the needs of your day. This is the same picture, only we've taken and separated the sympathetic and parasympathetic nervous system. And if you look on the right, the sympathetic fibers, which generally come out of the spinal cord, go to all the different organs in your body. And during the fight and flight response, you can have a dilated pupil, dry mouth, accelerated heart rate. You are able to open your airways and breathe, and it shuts down your gastrointestinal tract and changes the many of the functions of your organs and your bladder, and it triggers the release of adrenaline from the adrenal gland. The parasympathetic nerves come from high up in the brain and in the neck, and there's some fibers that come out on the very end of your cord that go to your bladder. And these have just the opposite effect. So you can judge by the manifestations in your body whether you have more sympathetic, more parasympathetic, and the balance. What we see in patients with orthostatic intolerance is an excess of sympathetic nervous system manifestations. The body has very complex mechanisms for controlling the circulation of blood. And this is a picture to remind you that arteries in the red in this picture take the blood that has been oxygenated in your lungs through your heart, and the heart as a pump delivers that oxygenated blood out to every small blood vessel in your body and delivering oxygen and glucose and other materials to your tissues. The veins are the system that do the reverse. They bring the blood, the blood that has lost its oxygen and done its duty, and brings that back to the heart to be reoxygenated in the lungs. There's high pressure in the arteries because that pump is a very strong pump, and the arteries are thick and elastic walled, and they are able to handle that high pressure. After the blood has gone through the organs and through the capillary bed, the system in the veins is a low pressure, sort of a passive movement, and it does have to go essentially uphill in many of the areas of the body to get back to the heart where it can be oxygenated. If you think about the veins in your legs, there is really no pump action left from the heart to bring the blood from your feet and legs back up to the heart. It's a low pressure system flowing uphill, and it's mainly accomplished by several things. One is the autonomic nervous system controls the tone and will constrict those blood vessels when you stand up to keep the blood from pooling. There are valves in the veins so that any action forward will gradually move that blood upwards toward the heart. And the actually pumping action comes from the muscles in your legs, contracting those veins so that the blood can return. So what are some of the things that can cause orthostatic intolerance? Well, any ordinary person can have orthostatic intolerance from becoming severely dehydrated, having internal bleeding, becoming overheated. Some people, when they sit in a hot tub too long, their blood vessels dilate. They get up to come out of the hot tub and feel like they better go a little more slowly or they're going to faint. Sometimes people faint when they see blood or have a stressful event. What a lot of people don't know is that if you're at prolonged bed rest, you can develop orthostatic intolerance. And we've learned this from space travel, that astronauts, it takes about 3 weeks where there's no gravity to inform the body about up and down. The astronauts develop severe orthostatic intolerance. And that's where some of this early research came from. But it's important for patients because if you spend all of your time horizontal at bed rest, you can develop orthostatic intolerance just from that aspect of deconditioning. Other things can cause OI. Certain drugs, diuretics, some kinds of antidepressants, some kinds of blood pressure drugs. There is a type of progesterone in some kinds of birth control called drospirenone that can lower your blood pressure. It's important to seek medical assessment if you have orthostatic intolerance that's not readily explained by your circumstances, because underlying heart disease or lung disease can manifest as orthostatic intolerance or fainting. And illnesses that directly impact the brain, such as Parkinson's disease or multiple sclerosis, can cause orthostatic intolerance. We know that damage to the peripheral nervous system, such as diabetic neuropathy, can cause orthostatic hypotension. And we think something called small fiber polyneuropathy may underlie some cases of fibromyalgia and ME/CFS. These are the very small nerves in your body that are out in the skin and control your organs and your circulatory system. This is just a diagram to help you understand the nervous system. The signals start in the brain and come down the spinal cord, and then large nerves come off called the peripheral nervous system, the cranial nerves and spinal nerves. And those nerves carry fibers that are motor fibers or signals going down to tell cells or to muscle cells, for example, to act or constrict. And then fibers coming back are sensory fibers that are bringing information from the body back to the brain. The motor fibers go to your voluntary muscles, your skeletal muscles, like the muscles that you use when you move your arm, but they also go to what are called smooth muscle and cardiac muscle. So these nerves of the autonomic nervous system control your heart rate and the dilation and constriction of your blood vessels, as well as many other organs in your body. And then you can see here how the sympathetic and parasympathetic nervous system are the divisions of the autonomic nervous system. Well, I put an X on the areas that are mainly characterized by small, very hair-like nerve fibers without insulation or myelin. And you can see that those are the areas that might be damaged in the case of a small fiber neuropathy or damage to those small nerves. So chronic orthostatic intolerance can be related to dysfunction of the autonomic nervous system, maybe toxic effects like some kinds of chemotherapy, autoimmune effects, even a virus itself can damage the small fibers, and there are probably numerous other causes of small fiber neuropathies. What's interesting is that orthostatic intolerance and dysautonomias are commonly found in people with fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, and hypermobility syndromes like Ehlers-Danlos syndrome. So the more important thing, because we may not always be able to tell exactly why the orthostatic intolerance is present, is to learn how to recognize and avoid common triggers. So if you have orthostatic intolerance, you'll probably recognize some of these triggers: getting overheated, being dehydrated, standing too long, even sitting too long with your feet on the floor. As we talked about, prolonged bed rest, confusing your autonomic nervous system and making your muscles weaker. And there are, as you know, medications that can worsen orthostatic intolerance. So you would want to do your best to recognize and avoid these situations if you have OI. What are some other things you can do? Well, you can strengthen those muscular pumps in your upper and lower legs by doing exercises specifically to make those muscles stronger and to use those muscles when you're feeling symptomatic. Even if you're not walking, you can flex and move those muscles. There are ways to be more friendly to your orthostatic intolerance when you're doing activities or exercises. If you think about it, it might make more sense to do your exercises lying down or in a chair, such as restorative yoga, being on a recumbent bike, using weights or bands, planks. Those kind of activities don't trigger the orthostatic intolerance as much, so you're able to get more exercise for the effort. And the other is exercising in water, because very often that puts you in the horizontal position, or you're standing in a pressure tank and it's almost like wearing compression to be in deep water, because the water pressure increases with every foot of depth. So you want to exercise with a goal of generally improving the strength in your legs and also your abdomen and low back in the trunk, and a little bit of encouraging general circulation from light aerobic activity when you can tolerate that. Before you're going to exercise, you should down some cold water about 20 minutes, 15 to 20 minutes before the exercise. And be careful, because after you do the exercises, you may be very vulnerable to increased orthostatic intolerance because the blood is out in the limbs and in the muscles from the exercise. So you should lie down and elevate your feet immediately after exercising, and be sure and cool down slowly, not stop abruptly, unless you're going to sit or lie down. And you should work very gradually into the cardio, especially because especially people with ME/CFS have a great difficulty doing aerobic exercise. And this should be adapted very specifically to each individual based on their tolerance. Those of you who can, if you can get in water, that's easier on your joints and your low back. The cool water helps constrict the blood vessels. And if you're in too warm of water, which is very comforting and helpful for pain, it might dilate your blood vessels. And then utilizing the water either horizontal or in depth, the depth of the water. What else can you do about orthostatic intolerance? Well, you should increase the volume in your blood vessels. You can do that by drinking extra water and fluids, by increasing your salt intake, and there are medications such as fluticasone that can cause sodium retention or increase the fluid volume. Rapid water ingestion can improve orthostatic intolerance within 20 minutes. So you can also compress those veins in your legs to improve orthostatic intolerance. You can do that externally with compression socks and compression garments, and there are medications also that constrict the blood vessels and help with making it a smaller tank. I put midodrine up here, which is a fairly common medication and available in generic. It's like wearing compression on your arms and legs. It constricts the blood vessels in those areas. Northera is a drug that is available on the market, but it's very, very expensive and maybe not available at this point. But I put it up here to say that there's a future in terms of drug development, and hopefully those will become more accessible to people who need medication to help manage their orthostatic intolerance. The next thing you can do besides increasing volume and increasing compression, we use low-dose beta blockers such as propranolol, metoprolol, or atenolol to control that rapid heart rate response. If you don't have a rapid heart rate response as part of your orthostatic intolerance, you might want to take care, because beta blockers can slow the heart rate too much and can drop the blood pressure. And also people with asthma, if you're blocking your beta-2 receptors, you won't be able to use your inhalers effectively. So this is just a reminder of the general approach to management. Once you've done all the care you can of your other medical conditions, the most important priority is pacing and activity management to avoid escalation of your symptoms. Then you want to be sure that you have restorative sleep, improved pain, that you're in a mentally more balanced place and feeling more confident, and fitness, working on the strength you can as tolerated by your illness. And if you have orthostatic intolerance, knowing about it and treating it might improve your symptoms and function. So thank you for listening today. I've put up here the other classes that we're recording that you can have access to, and I hope they would be useful for you. And these are some common orthostatic intolerance resources online that you might find helpful if you want to learn more. Good luck.